Aloha, everyone. Thank you very much for joining us tonight for this Hawaii Pacific Health webinar focused on breast cancer. My name is Dr. Jeff Killeen, and I'm here to hopefully facilitate today's webinar and conversation. This Hawaii Pacific Health webinar event is focused on breast cancer. We hope this is just a nice conversation amongst us all, but our topics that we'll hope to cover tonight include prevention and screening, statistics and information specific to Hawaii, some of the current and cutting edge treatments that are offered and available, and how you can best work with the care team to receive the most comprehensive and effective treatment possible. Before we get started, just a couple of reminders for all of our viewers. Today's webinar will be recorded. After the event is complete, the registered participants will receive a copy of the recording. The event will also be available to view on the Hawaii Pacific Health social media channels and website. For those of you joining us live, please feel free to submit questions using the Q&A button that you should see at the bottom of your screen. We'll do our very best to answer as many questions as possible. Some questions have come in during the registration process, so hopefully we'll answer some of those as we go through the program, but at the end, we will have some time to specifically ask some questions that maybe we haven't gotten to. So without any further ado, I'd like to introduce our very distinguished panel here. First, my role in this, I am the medical director of the oncology service line for Hawaii Pacific Health. I'm also an active member of the breast cancer team in that I'm a diagnostic pathologist in breast and gynecologic pathology based out of Kapiolani. But I'd like to introduce the rest of our panel, and I'm happy to say that I think every one of these people I've known ever since they came to our organization, and most of them I was involved in recruiting. So this is really a great opportunity to just sit down and talk with some key members of our care team. First, I'd like to introduce Dr. Jamie Fukui. Dr. Fukui is an associate professor at the University of Hawaii Cancer Center, in addition to working with us here at Hawaii Pacific Health. She is a breast medical oncologist. Her interests are obviously in breast cancer, in particular in clinical trials and translational research, developing clinical trials protocols, and providing cancer care to the residents all over the state of Hawaii. Second, I'd like to introduce Dr. Brian Gushkin. I've known Brian for many years. He's a diagnostic radiologist specializing in women's imaging at the Kapiolani Women's Center. He's been the imaging director there for over 20 years, so I guess I've known him for over 20 years. Dr. Chris Token is a breast surgical oncologist. He has a very unique background and training. He's trained in breast surgical oncology as well as fully trained in plastic and reconstructive breast surgery for both benign and malignant breast diseases. And finally, Dr. Laura Peterson, who I've also known ever since she's been here, upwards of, 15, 16 years. Dr. Peterson is a breast specialty surgeon operating out of Kapiolani Medical Center, and her entire career has been dedicated to the advancement of breast cancer surgery here in Hawaii. So with that introduction, again, like I said, I'd like this just to kind of be a conversation amongst us all, trying to develop some themes throughout the hour that hopefully you'll notice and we can emphasize again at the end. But I'm going to start out just with a few kind of basic statistics as kind of an introduction of what we're going to be talking about, and then we'll go into some specific areas, kind of like how a patient might work through the system with breast abnormalities and a breast cancer diagnosis. But this first screen that we're showing here, we did get a lot of questions about general breast type statistics, both worldwide and in Hawaii. So if you see this large map, the only thing I wanted to point out in this is that the dark blue countries represent the countries with the highest incidence of breast cancer. And you notice that a lot of those countries are what we might probably would think of as the most developed countries. So it might seem a little unusual that the most developed countries have the highest incidence of breast cancer. Could you go to the next slide, please, Courtney? This is honing in on the United States, and in this map, it's the red that is the highest incidence of breast cancer amongst all the states in the Union. And again, notice the highest states, one of which is Hawaii. So that might alarm some people in that the highest incidence of breast cancer, Hawaii is one of those states. Let's go to the next slide. This is breaking down even Hawaii itself, and you can see how breast cancer diagnoses in the state of Hawaii differ amongst the different islands, relatively following the population densities. Okay, could you go to the next one? This is diagnosed cancer cases in women in Hawaii over a 5-year time period. And notice that breast cancer diagnosis accounts for over 1/3 of all cancer diagnoses in women. And you can see other types of cancer in the female population. The next one, please. This actually shows cancer deaths amongst females in Hawaii. And notice that breast cancer is no longer the leading cause of death in females. It is one of the leading causes, but this is where, and I'm sure many people have seen how lung cancer rises to the top as far as cancer deaths. Next one, please. This now relates to what I mentioned before, how it might seem a little unusual that some of the more developed areas have the highest rates of cancer. This is a map that shows how commonly mammograms are performed in different states. The dark blue are the states that have the highest usage of mammography. And you'll notice that Hawaii is in one of those categories as being the highest use. So the incidence of breast cancer being in Hawaii is directly related to that lots of mammograms are performed in Hawaii. And we'll see that as a theme in that the incidence of breast cancer is related to how often we look for breast cancer. Next one. This is an interesting graph which shows a green line, which is the incidence of breast cancer. And you can see that it starts in 1987 on the left, and you can see that it's gradually gone up. That's how many breast cancers are diagnosed. But you'll notice the bottom line that goes down a little bit is actually mortality from breast cancer. And so what this means is, although we're finding more breast cancers, we're getting better and better outcomes from those breast cancers. And that's also related to the higher use of mammography so that we find things at a smaller size and earlier stage. Next one, please. This was just a little breakdown. Some people are interested in the ages where breast cancer is diagnosed. This is a graph which shows different age groups. You can see the most common age group is 55 to 64. One thing I wanted to point out that we often hear about when mammography is to begin, whether that's age 40 or 45 or age 50. But notice if you start mammography at age 50, there's several of these bars to the left of the graph where there's breast cancer being diagnosed before we've even recommended mammography. The next one, please. And finally, this is always a question, especially here in Hawaii, does race and ethnicity have much to do with this? And the answer is yes. You can see different ethnic groups here and their incidence of breast cancer, which is the green bar, and the mortality from breast cancer, which is the red bar. And you can see that, relatively speaking, the Native Hawaiian population is overrepresented in both of those. The next one, please. So everybody loves to see pathology slides. So this is my little time to talk about pathology. And I'm not going to go through this in much detail other than to make a point. Each one of these 3 pictures is under the microscope, which is what I do. And each one of these 3 is an example of breast cancer. And the point being is that none of these 3 pictures look anything alike. And the lesson from that is that breast cancer is not one disease. It's many, many diseases, and there are many things that go into determining how a particular breast cancer is going to behave in a particular patient. Next one, please. And it's not just under the microscope that these things are different. This is an example of one of the I just showed, but what it shows is that when we look for other aspects of a tumor, we also find lots of differences. The picture on the upper right is a microscopic slide that we have stained to highlight estrogen receptors. Many breast cancers are estrogen dependent, and we do this on every case. You can see that there's lots of brown dots. What that means is this tumor is strongly estrogen receptor positive. And so it's likely that that will be taken into account in its management. The bottom picture on the right is for another protein we look for called HER2/neu, which is a molecular marker for behavior and can be the target for a drug. And notice that nothing is brown, so it's completely negative. And then my last picture is the next one. This looks at one of the other tumors, and you can see that same stain on the upper right that was very strong before is now completely negative. And the stain on the bottom right, which was completely negative, is now very strong. And so what that means, and what the point of this, again, is to highlight that even down to the molecular and genetic level, every breast cancer is different. And so what that means is that we really need to look at every case on a personalized basis and construct the appropriate treatment plan for those cases. So with that, we're going to move on, and I'm going to kind of go on, try to work through how somebody may be presenting. But one of the common questions we received in the pre-questions, and what we hear a lot is, of course, people are interested in how can I prevent this from even happening? I've pointed out how mammography detects cancers, and mammography actually will increase the number of cancers we find, which is why we do mammography. We want to find them early. But many people have questions about prevention. So I'd like to ask Dr. Fukui, when you're approached with a patient about, well, how can I even prevent this from happening in the first place? Are there any dietary things or activity things or behavioral things, genetic things? What can I do to try to prevent breast cancer from happening?
Yeah, that's a great question and really common. We call some of those risk factors. So there are some that are well known that can increase a woman's risk of breast cancer. And most of those tend to be focused on genetics. We can't change our genetics or our family history, but if someone does have a lot of family members with cancer, that can predispose somebody to developing breast cancer. Just by being female, because of the increased risk of hormone-positive breast cancer, that increases someone's risk. As far as diet and lifestyle things, there hasn't been shown to be one diet that is better or worse than others. However, in general, a heart-healthy diet has been shown to be helpful at prevention. And so that is something where there's a focus on plant-based foods, as well as less processed foods or fried foods. And we often do implement that as well after someone has treatment to help reduce the risk of having the breast cancer come back. There are some other lifestyle interventions or things that we can do to help reduce risk of cancer in general and overall stay healthy. And one of those is exercise. So getting at least 30 minutes a day of some kind of brisk physical activity is important. And that includes things like running, walking briskly, anything to get the heart rate up. And then finally, you had mentioned some other lifestyle things, and I want to mention stress, especially during this time of COVID. It's been known that stressful events, whether that is a divorce, loss of a job, bankruptcy, all of those things can also, traumatic events can increase someone's risk of developing cancer in general. And so finding ways to deal with stress is very important.
Okay, thank you, Dr. Fukui. So now let's say we're headed for the imaging center for mammography. We all have heard about screening, the role of screening. Dr. Gushkin, could you tell us a little bit about some of the standard recommendations regarding screening, maybe some of the controversies with those, and what somebody should know when they're going to their screening exam? What kind of information should they make sure is known? And what kind of conversations do you have with patients actually coming in for screening?
Sure. Before I start, thank you everyone for making us one of the top states in the country for mammogram screening. That's great. We like to hear that. So with screening recommendations first, there's a lot of different recommendations out there. Some of them say to start at age 40. Some say start at age 45. Some say it's even okay to start as late as age 50. Most, however, say to come every year. Some say it's okay to come every other year. So it can be confusing to patients. When do I start? How often do I go? Well, many major medical societies still advocate the traditional recommendation, and that is to start at age 40 and to come every year after that. That's what we recommend at Hawaii Pacific Health. We try to keep it simple. Start at 40, come every year. Now, keep in mind, that's for the woman at average risk for breast cancer. What about women that may be at higher risk? And Dr. Fukui discussed some of the potential reasons why you might be at higher risk. A common one would be family history. Some of these women may need to start earlier with their screening, earlier than age 40. You saw that graph. There's a lot of people, well, not a lot, but there's a fair number of people that present even before age 40. Some of these patients that are at high risk may also be eligible for supplemental tests in addition to their annual screening mammogram. For example, screening breast MRI. So one of the things that you're gonna have to come prepared with is you're gonna answer questions about whether or not you might be at high risk, and the technologist will go over this with you. Now, you may wonder, why are the guidelines all over the place? Well, they're all looking at the same data, the same studies are out there, so how can that be? Well, what it really comes down to is what each guideline wants to emphasize and what they feel is important. So some guidelines say, let's find as many breast cancers as possible and find them as early as possible. Naturally, those are going to say come early and come every year. Some may want to minimize the anxiety and stress of what's called a false positive result, where there's an abnormality that turns out to be nothing when you go back for extra pictures. That can be anxiety provoking. Yet other guidelines may say, well, let's contain costs. Let's limit costs on this. So they all have their different reasons for wanting to put out different screening recommendations. Now, what they all have in common, though, is that they all say that you as a patient should talk to your doctor. Talk to your doctor about your individual situation, especially if you're high risk. And together, you can come up with the plan, when you want to start and how often you want to come. Now, sometimes we get questions at the other end of the spectrum. When should I stop? When is it okay for me to stop getting mammograms? You'll commonly hear age 75 thrown out there. Fortunately, we don't have an age limit in the US as to when you have to stop or when you can no longer get mammograms. At our center, we have a lot of patients in their 90s that still come in every year for their mammograms. What the guidelines recommend is that you first look at your overall general health. If you're in pretty good general health and your life expectancy is at least 10 years, yeah, keep coming if you want to. It's really, really up to you. So for the average woman, start at age 40, come every year. When to stop, look at your overall health. Bottom line, talk to your doctor for what's right for you.
Okay, thanks, Dr. Gushkin. One question I wanted, because I want to make sure we get to this, because I know it's happened at times. A patient comes in for screening, but they've felt something. So they may be thinking, okay, I'll just go have a mammogram. We know that mammograms aren't perfect. There are certain kinds of patients where they're more effective than others. What would your advice be to patients who are actually coming in, but it's not really a screening mammogram? There's actually an abnormality that maybe they felt or sensed or a partner has that actually needs to be evaluated.
Okay, great question, and it comes up all the time. So, a lot of times this is caught at the scheduling process. There are two different types of mammograms that you can come for. One is a screening mammogram. By definition, a screening mammogram is your annual mammogram where theoretically you have no problems. Okay, so that's a screening mammogram. It's a test where you're allotted about 20 minutes, the pictures are taken, you leave. You get your results later in the mail or on my chart. Now, the other type of mammogram is called a diagnostic mammogram. This is a problem-focused mammogram. It's for women that have specific problems. Like Dr. Colleen said, the most common one would be a lump in the breast. or new focal pain, or maybe they've had a history of breast cancer, things like that. Now, this is a different kind of mammogram where we're going to allow more time. We're going to tailor the exam to the problem that you have. We're going to take special pictures. We may even add an additional test like an ultrasound. These appointments can take as long as 2 hours. So we ask that you allow us a lot of time because we may need to do additional tests. The radiologist will look at your exam while you're here. You will actually, in most cases, get your result, sometimes even from the radiologist, before you leave. So it's very, very important that you distinguish between these two types of mammograms when you come in. Screening mammogram for no problems, diagnostic mammogram if you have a problem. And again, this is best solved by talking to your doctor. If you have a problem with your breast, the first person you should go to is your doctor, identify the problem, and your doctor can schedule you for the appropriate type of test.
Okay, thanks, Dr. Gushkin. So in some cases, the ultimate outcome of what Dr. Gushkin has described is that a biopsy is taken. And that's always done in the least invasive way possible. And that usually means a needle biopsy done by one of two techniques, either via ultrasound guidance or via what we call stereotactic guidance. And that's when the pathologists come into play, because when Dr. Gushkin supplies that tissue for us, we make the diagnosis of whether that's a benign condition or whether it's breast cancer. So let's go to those cases where that biopsy might have shown breast cancer. And at that point, that's where our surgical team and our medical oncology team might come in. So I'd like to ask Dr. Peterson, when you first see a patient coming in with that core biopsy diagnosis of breast cancer, what can a patient expect to hear from you in that first conversation, and what kind of things are you thinking about in kind of the initial treatment planning?
Great, thanks, Dr. Colleen. I do want to say quickly before I go on to the answer that question that it's critically important that anyone, if you feel anything in your breast, that you mention it when you come into your mammogram. Even if you haven't told your doctor, tell the technologist, because I see multiple times a year where someone felt something, they got their screening, it came out negative, they thought that was enough, but it wasn't enough. So it's really important to say if you have any symptom. So I'll go ahead and talk about a little bit. So you have a biopsy that shows cancer. What am I going to talk about? What am I going to look for? So one of the things we look for is the extent of the cancer in the breast. How big is the lesion? Is there more than one lesion? Is there a large area of calcium spots? So we're looking at that information. We're looking at, is there any suspicion that lymph nodes are involved? So we're doing that by both imaging and by physical exam. And then we're looking at the biopsy results. So Dr. Colleen will give us information about the cancers. Is it estrogen positive or estrogen negative? Is it HER2 positive or HER2 negative? So we're putting all that information together, and then that's when we kind of come up with our comprehensive plan. And the surgeon is often the person who kind of starts that out as the first person to see the patient after they've been given their results showing breast cancer. So I try to go over the overall treatment plan, all the different parts of cancer treatment, including surgery, chemotherapy if it's needed, radiation if it's needed, and anti-estrogen pills if they're needed, and then kind of come up with the plan of, is this more likely to be something that we're going to go straight to surgery, or are we going to need additional testing first? Maybe we need additional imaging to see if it's spread elsewhere, if it's a larger cancer, or if we think lymph nodes were biopsied or are involved. Then we're going to look to see if it's spread other places before we do any surgery. We might also consider, for certain types of cancer, like HER2 positive cancers, we might consider doing some chemotherapy before surgery. So we'll want to involve the medical oncologist in the treatment plan before we make a surgical plan. But in terms of doing a surgical plan, we're often discussing saving the breast and taking out the tumor area, called breast conserving surgery or lumpectomy, versus doing a mastectomy or removing the entire breast either without reconstruction or with some plastic surgery reconstruction. And when we're making those decisions, we're mapping out the cancer in the breast. And I think, one thing that can be confusing sometimes is we can have a cancer that's more aggressive and needs chemotherapy and has lymph node involvement, but the tumor itself in the breast is still okay to remove locally. And we can have the opposite situation where we have a very early cancer, even stage 0 or stage 1, but it can be multiple spots in the breast or very extensive. And in those cases, we really can't take it out locally and we need to go to a mastectomy. But if we can save the breast, in general, we try to do that because there's no survival benefit from taking the entire breast for breast cancer. So we individualize the plan based on the exam and the imaging and the type of cancer. And then we also add in genetic information. If there's a gene abnormality, we might be more likely to recommend mastectomy because of the risk of a second cancer. And then we take into account also people's individual preferences in that as well.
Okay, thank you, Dr. Peterson. So Dr. Token, most people are familiar with, the typical surgical approaches, a lumpectomy or partial removal of the breast or a mastectomy. What are some of the newer technologies or techniques that you can use to both address the primary tumor in the breast as well as evaluation of the lymph nodes? Because we know that if you go back 10, 20 years, some of the main adverse effects following surgery had to do with arm swelling, things like that. What is the current state of trying to minimize the effects of surgery and maybe even make improvements using the surgery?
So I think when we talk about breast cancer surgery, we tend to lump them into breast conservation or lumpectomy and saving the breast, and then mastectomy or not saving the breast with or without reconstruction. Lumpectomies can be performed various ways. One way you can do it is just standard, incision over the cancer, and then take the cancer out and then close the breast up. And then the other way you could do it is something that we tend to refer to as oncoplastic surgery, or using breast lift or breast reduction type incisions in order to take the cancer out. Both of them are considered breast conservation. And we can do that with or without wireless or wire localization. So oftentimes when we can't feel the cancer or we want to make sure that we get it, we stick a wire in it, or our radiologist partners do to help us as surgeons find it in the operating room. And we've just adopted wireless technology, so using magnets in order for to help the surgeons find those lesions. And we use that also to help us find lymph nodes that we know to be positive. And I think from a surgical perspective, looking at the lymph nodes, our main goal right now is de-escalation of severe lymph node surgery, because we know that oftentimes when we take a lot of lymph nodes out from under the armpit, we can get pretty bad arm swelling or lymphedema. So whenever we can de-escalate surgery from that standpoint, we try to. Some of it involves being able to localize the lymph nodes once we know they're positive. And some of it involves treating them with neoadjuvant or before surgery chemotherapy in order to get those lymph nodes to shrink down, and then taking them out with that wireless technology. So I think both of those play a role in trying to limit lymph node surgery.
Okay, thank you, Dr. Token. So Dr. Fukui, sometimes medical oncologists such as yourself come in after the surgery and give recommendations. It's becoming more and more common where all of these discussions amongst pathology, surgery, radiology, and medical oncology actually happen prior to the first definitive treatment. What are some of the issues now that in breast medical oncology are kind of moving potential treatment by yourself more to the front end of management rather than following surgery? What kind of discussions do you have with your surgical colleagues? Oh, you're on mute, Dr. Fukui.
Thank you. I just want to step back and say that there are different kinds of breast cancers. So when we talk about, and when Dr. Colleen was showing those slides before, it really depends on the subtype of breast cancer. So most commonly, they're the hormone-driven kind, and often those patients do require surgery first. And there are special tests that we can do to figure out whether or not chemotherapy would be beneficial afterwards. But there are certain subtypes of breast cancers known as triple negative, where there isn't growth because of these hormones, and there is not this HER2 protein that we see. That's called triple negative. And then the HER2 positive kind of breast cancer has this HER2 positive protein. And so in those two types of breast cancers, we often implement chemotherapy or treatment first to shrink down the tumor. And so standardly, when someone is being seen for that subtype of breast cancer, I usually will see them as well early on to help shrink down the tumor with treatment.
Okay, thanks. And what is the role, do you see it as on the research side as clinical trials? Talk to us a little bit about your role at the Cancer Center and what the advantage to a patient may be of entering in a clinical trial and what's involved in that.
Absolutely. So clinical trials just are not treatment trials. They could be at any point along the continuum, from prevention to screening to treatment to survivorship. And so we often tend to think about clinical trials in the more advanced or metastatic setting, but they can happen at any time. I also work at the University of Hawaii Cancer Center, where we actually vet and go through a lot of the protocols here on island. And HPH does open a majority of those trials through the consortium, through University of Hawaii Cancer Center. And so whenever we see a patient initially and have a conversation about a diagnosis, or even in high-risk clinic for those who might be at increased risk, we're always looking to see, will they benefit from a trial or a study that could potentially give them an added layer of support or an added layer team, a support research team to go through their journey. And so right now we have several clinical trials open that Dr. Peterson is the principal investigator on, and I have several as well that are open here at Kapiolani, where I'm principal investigator on, and some of the other colleagues here. And so I wanted to also mention there's a screening trial looking at 3D mammography versus 2D mammography, which I know was one of the questions that was in the chat box, looking at what is it beneficial to do 3D versus 2D for screening? And we don't know quite yet. We hope that this clinical trial will help us determine which one might be better for screening. And certainly in our population, we know that the women tend to have denser breasts in our population. And so it's a little bit harder sometimes to screen for new lesions or new masses or new things that we have to be aware of. And so it is something that would be tailored to our population here in Hawaii.
Okay, thank you, Dr. Fukui. So let's take a few minutes, because I know some of the questions that have come in before relate to this, and I know you hear things on TV about delays in treatment or in diagnosis based because of COVID. I'd like maybe each of you to just briefly go through, what happened during, especially the initial phases of the COVID pandemic. How did it affect the practice, the patient management, and where things are right now? How about you, Dr. Gushkin? What was the effect and what's been the outcome down in the imaging centers related to COVID?
Okay. So like everyone else, in the spring of 2020, we did have to shut down. We stayed open for emergency things, lumps and things and biopsies, but our screening program did have to shut down for about 6 weeks. When we did reopen in the summer of 2020, it was a careful reopening because we had to distance everyone. We made sure the staff was masked and shielded. And of course, patients had to wear masks or still wear masks throughout the duration of their visit. We've since been able to ramp up to our normal volumes. And, to be honest, we've caught up. There hasn't been a huge drop in patients coming through. Our message has always been, do not delay your mammogram because of COVID safety concerns. And I think that message has been put out because people have been coming back. So we haven't seen a huge impact yet, at least in our screening population here.
Okay, thanks, Dr. Gushkin. How about on the surgery side, Dr. Peterson? I know we had many meetings in our weekly breast conferences about, you know, what to do, wondering what would happen with the ORs, whether they would have to be shut down and to what extent. What kind of thought processes went into your mind during, especially the peak of the COVID pandemic related to surgery?
So in the spring of 2020, our operating rooms completely shut down except for emergency cases. And so we were being asked to triage even cancers, and not all cancers were up to the point of being considered emergent. So again, with these different individual cancers in individual people, we had to look at which were the higher risk cancers that couldn't wait, and which were the cancers that progressed more slowly or maybe could be temporized with anti-estrogen medication, especially those estrogen positive cancers. So we were able to do some surgery, but we had to really be careful and tailor our surgeries. So there were patients that had to delay surgery for a couple of months and take pills while they were waiting for surgery to try and kind of keep the cancer in check, if you will, while they were waiting for surgery. And these was all based on national surgical and breast, the American Society of Breast Surgeons and the American College of Surgeons recommendations for treating breast cancer from a surgical standpoint, to triage patients that were able to wait versus those that needed to go forward. One thing I did notice though is that we had probably a bump in the number of women who were too afraid to have surgery at all and have continued, in fact, to delay surgery. So at this time, we are fully open for surgery. We are treating breast cancers the way we did before the pandemic in terms of getting surgery in a timely fashion without restrictions. So we're able to do everything we need to do. Incidentally, though, I've noticed quite a few patients I'm seeing diagnosed this year, their last mammogram was in 2019 and they sort of skipped 2020, or maybe they're half a year late or something like that. So I think we're definitely able to be up to full volume about, with taking care of everybody, but a lot of people kind of missed that little screening time in the spring and summer of last year.
Thank you. How about your practice, Dr. Token? I know you also operate quite a bit at Polymomy, which is more of a general surgical hospital, not as much of a specialist. Was there difficulties with breast cancer surgery, given that you were having to deal with not only the breast cancer patients, but a wider spectrum of surgical cases that needed to be into the OR?
No, I mean, I think that like Dr. Peterson said, most of the steps that we were taking during the time we were shut down a year ago were preventative, and we were discussing patients about potentially holding off their surgeries. But in general, we have not had any real delays in surgery, even now. So we're just full speed ahead.
Okay. And Dr. Fukui, I know that when we were having those breast conferences related to, is this a case that can be delayed? Does it need to go straight to surgery? Do they need to start chemotherapy right away? When people hear that surgery may have been delayed, there's an obvious concern of, well, what does that mean as far as the cancer and my prognosis? What kind of data was used to kind of put into place when these cases are discussed? For example, if you're going to delay surgery, but it's an estrogen responsive tumor, what's the role of estrogen therapy in not leading to an adverse outcome if cases are delayed?
Yeah, so in general, the whole US actually got together, and there were thought leaders and experts that came up with guidelines, and it was safe to delay surgery in certain circumstances, including hormone positive breast cancers that were early stage. They could go on anti-hormone pills for the time being, and that's perfectly safe. And we often will implement that in the non-COVID case as well, for certain people that need to delay surgery for other reasons. So it was kind of nice to have those guidelines and utilize that. Of course, if there are people who absolutely needed to get treatment or surgery, they were proceeded to that treatment.
Okay, thanks, Dr. Fukui. So we're getting close to our Q&A period. I guess I wanted to just tie up this little discussion about COVID just to say that, and we all remember those times well. Everyone at the time was concerned about delays, about whether we would have, personal protective equipment that was going to run out. That's the main reason the ORs went down. But I can assure everyone listening is there were many discussions on all cases. We immediately put the word out from our oncology service that cancer surgery is not an elective procedure. Cancer surgery is a very important procedure that should not be delayed. In addition, though, there are certain cases, and there's data to support that delays can occur without adverse outcomes for certain types of breast cancer cases that Dr. Fukui was talking about. So this was a very thought out process using national guidelines and a multidisciplinary conversation about what cases were safe to delay and which cases absolutely could not be delayed and needed to go immediately on to treatment. So I think with that, we'll move into our Q&A portion, which is going to be kind of some of the same conversation. I'm going to circle back to maybe some things that weren't covered, but make sure that we deal with some of the questions. They're maybe a little trickier to answer. So the first question I'm going to queue up is actually for Dr. Gushkin, and I'm not sure how anxious he is to answer it, but he's going to have to give it a try. And that's, we get a lot of questions regarding dense breasts. And many people have read information about it's a higher risk for breast cancer. It's more difficult to detect. Mammography doesn't work as well. Dr. Gushkin, I guess for one, is there anything that can be done to decrease the breast density to make testing more effective? And what role does 3D mammography have in addressing the problem of dense breasts, as well as other modalities?
Okay, so yes, this is I could take up the whole half an hour or 15 minutes with this topic, but I'll try to keep it brief. So dense breasts is our Achilles heel, if you will call it, in imaging. It makes it really hard for us to find breast cancers, and we're constantly looking for ways to get around the problem with dense breast tissue, because basically the overlapping tissue can hide cancers. There have been several advances over the years. I saw a question in there about digital mammogram versus film mammogram. That was a big advance right there, going to digital. That helped us with dense breast tissue. There's supplemental tests, for example, ultrasound or breast MRI, that can also help with dense breast tissue. I can't go in too deep into those because those will take a lot of time as well. The big advance that we've had in the last decade that can really, really help with dense breast tissue is the 3D mammogram. And the great thing is it's now widely available. Just about every breast center you go to has 3D mammography. So it's something you should really consider. What the 3D mammogram does is it actually takes a series of images through the breast. A computer then reconstructs these images into very, very thin slices through the breast tissue. So we're looking at 50 to 100 pictures for each breast. But the advantage of that is you now minimize that overlapping tissue. We can look at each section, very, very thin slices. The cancers appear, they're more conspicuous. So we as radiologists see the cancers more easily this way. And it especially helps in dense breast tissue. Now, Dr. Fukui mentioned a study ongoing about whether it helps or not. The data that is out in the radiology literature varies between 20 to 40% more breast cancers detected. It depends on your population. What we don't know is the 3D mammogram ultimately increasing your life expectancy? In other words, by finding these cancers earlier, did we really make a difference compared to when the 2D mammogram would have found that cancer? Now, we talk about dense breasts. The 3D mammogram can also help in patients that don't have dense breast tissue. So we actually recommend that in all patients should consider getting that 3D mammogram because it really, really can help. And we see it pretty much on an almost daily basis where we can see things on that mammogram that don't appear on that regular 2D mammogram. So
Okay,
that's a brief
thanks,
attempt.
Dr. Gushin. I'd like to circle back to Dr. Token. You had mentioned briefly oncoplastics. That might be a term that people have not heard much. Maybe you could just real briefly tell us what that is. Who's the ideal patient for an oncoplastic approach? And are there certain things that make reconstructive surgery more difficult or even not possible? For example, things like heavy smoking histories, obesity, any other health conditions that just make some of these reconstructive approaches and oncoplastics difficult, or what can make it a really good option for patients?
Sure. I think when we talk about oncoplastic surgery, we're usually talking about breast conservation. So lumpectomy or saving the breast and then trying to rearrange the breast in a particular way that's more cosmetically appealing. And I think we often think about oncoplastic approaches as either volume displacement or volume replacement. Volume replacement is quite difficult. And so volume displacement tends to be the patient who's more ideal for an oncoplastic approach. And so that's either with a small breast reduction or breast lift that can rearrange the tissues into a nice breast shape. And then we can do a symmetry procedure on the other side. When we look at breast reconstruction, sorry.
We'll move to Dr. Peterson while you get a drink of water, because I was going to ask her something. One of the cases that we started to see several years ago and see increasingly is a nipple sparing procedure. Could you tell us briefly what that is and what particular patient or tumor characteristics are good candidates for that procedure?
Sure. So nipple sparing surgery basically means we're saving the nipple. We're only saving the skin in the nipple. We're not saving the tissue underneath, because part of a mastectomy is removing all of that breast tissue. So there's basically two approaches when we're doing reconstructive surgery along with it. So this is techniques that involve the reconstructive portion of surgery as well, so the implant placement. We save as much skin as we can to make it look as nice as possible. And when we can, we like to save the nipple because it looks more natural. It looks more like the person's own breast started because it's their own nipple. So one thing we look for is, from a cancer standpoint, is it safe to save the nipple? And that has to do with how far away the cancer is from the nipple. And the general guideline is the cancer needs to be over 2 centimeters away from the nipple to qualify for nipple saving surgery. So if the cancer is in the upper outer breast, far away, we can save the nipple. We always test the tissue behind the nipple to make sure there's no cancer there or within 2 centimeters of it, because that increases the risk of something coming back in the nipple area. But from a cancer standpoint, that's our primary criteria. But there's also a cosmetic criteria, and I don't know, maybe I can let Dr. Token talk a little bit about the cosmetic criteria, but essentially we're saving it for appearance, and we can hide the incision better underneath the breast where you don't see it, and save all of the skin and nipple so that it looks much more natural once they're reconstructed. So it's an ideal procedure to be able to do, but it isn't possible to do that on everybody.
Okay, Dr. Token, you're back from your pager going off. So want to maybe tell us a little more about a nipple sparing procedure, and also what kind of conditions of the patient, risk factors, smoking histories are important when you go into a discussion about reconstruction.
Sure. When we talk about oncoplastic surgery, there's not a lot of contraindication to that, other than if someone has a lot of risk factors. So smoking, obesity, or problems with wound healing, because those are just usually bigger incisions. When we talk about implant-based reconstruction, though, there are certain certain risk factors that significantly increase the risk of reconstruction failure or implant loss. And I talk about this frequently with patients because it's hard for us to say no, but sometimes no really is the best answer. If someone's a smoker, that does not necessarily mean that they can't have an implant. It does usually mean we can't safely save the nipple. And so that's a question we get often. If someone's BMI is greater than 40, their complication rate's probably greater than is 100%. So they cannot get an implant. Those are the big ones.
Okay, thanks, Dr. Token. I'm sure one of the questions probably that Dr. Fukui gets and Dr. Peterson gets and Dr. Token is, I've been diagnosed. I often see maybe a naturopathic doctor, homeopathic doctor. We hear about alternative kinds of treatments. How do we incorporate, if any, more alternative type therapies into breast cancer diagnosis and management? Let's have Dr. Fukui address that.
Sure. So there was a large study that was done looking at alternative treatments replacing our standard treatments. And it did show if they are replacing our standard treatments that unfortunately they don't do as well. And that's just because a lot of these supplements and alternative treatments don't go through the rigorous studies as our drugs and our standard treatments through clinical trials. However, for complementary things that are additive to some of the treatments that we give, they can be very helpful. And so I often refer people to a website known as Memorial Sloan Kettering Cancer Center Herbs, which you could Google, MSKCC, and it's an online resource for complementary supplements and just an online library about if there's any drug-drug interactions, any side effects to be aware of, any things to be aware of, since often these herbs and supplements and these things can often cause side effects, and we want to, of course, avoid that. But if they can be helpful, I think it can be very useful.
Okay, thank you, Dr. Fukui. And I'm going to stay with you. Another thing we haven't really talked about much is treatments. Patient's been diagnosed, treatment has been done, treatment has been completed. The interaction of the patient with our care team has really just begun. We have a whole lifetime of survivorship to manage and work with the patient. What are some of the key aspects in that, what we would call survivorship period, to make sure that other health conditions aren't ignored? And many of the questions we've got have to do with the risk of cancer after diagnosis and treatment. In other words, the risk of another breast cancer. What is a survivorship program, and what does that entail?
So a survivorship program is multidisciplinary. So it includes a number of clinicians, including your medical oncologist, your surgeons, your primary care doctor, nurse navigators, and continuing with breast imaging if that is the case, with the radiologists. And so part of the lifestyle things that I discussed earlier that could be potentially changed as risk factors for developing breast cancer in the first place can also be implemented as part of reducing the risk of having breast cancer come back. So it was mentioned in the chat that I didn't really discuss obesity, but it's been brought up a few times. And we do know that in postmenopausal women, having a greater BMI increases a woman's risk of hormone-positive breast cancer. Once somebody does have hormone-positive breast cancer, having an elevated BMI also is not a good thing. And so it's encouraged to exercise at least 30 minutes a day to help reduce your risk of developing that again. There are clinical trials right now looking at diet changes for how to do that, exercise strategies for how to do that. And often we are encouraging people to implement lifestyle changes, since that is something we have control over, to help reduce the risk of recurrence.
Okay, thank you, Dr. Fukui. In our last few minutes, one thing I wanted to at least briefly talk about, and I'm going to ask Dr. Peterson to address this, just to kind of give a visual or a picture of what it's like in a multidisciplinary breast conference. Because what we've tried to get across tonight is that breast cancer is not one disease, it's many diseases. There's many people involved in the diagnosis and the management. We do know, though, that 70 to 80% of breast cancer cases will start out with a surgical approach. So that puts the surgeon in a key spot to try to facilitate, what direction is this case going to go? What's the role of a multidisciplinary conference, Dr. Peterson, in helping you come to that decision?
Well, I guess first I'd like to say that it is very important to find somebody who specializes in breast care for your treatment, because since the surgeon is often the first person to see the person, they need to know the details of cancer. They need to know the different types of breast cancer and how the approaches might differ, and why in some cases surgery is not the best first approach. So it's important to have somebody who's well-versed in breast cancer and does treat a lot of breast cancer. But essentially our conference involves meeting together our radiologists, our pathologists, our surgeons, our oncologists, our radiation doctors, and also our genetic counselors, our nurse practitioners. I mean, we have a whole wide team that meets together, and we can talk about these cases, show the pictures, show the pathology, bring up questions and discuss amongst our group why one might take one approach versus another, especially if it's kind of a borderline situation, and or if we have questions that we need to answer as a surgeon before we go back and do surgery on this person. Are there other things that need to be addressed? Are there other things that should be biopsied? Is radiation contraindicated? And these kinds of questions we can bring up at the conference, look at everything together, and come up with a treatment plan that involves all of our specialties together. And then as a surgeon, I really appreciate that, because I can take that information back to a patient too, before they even necessarily meet with the other specialists, and we can come up with kind of a comprehensive plan so they know what to expect. But it's great to hear the discussion. I always learn things, even though I've been doing this for 20 years, I still learn things in conference regularly, talking with my colleagues who are experts in their field as well.
Okay, thank you, Dr. Peterson. And I really wanted to finish with that because we're kind of getting here to the end of our time. I think we just have a minute or two left. But I wanted to kind of circle way back to the beginning when I said there were some themes that we wanted to really, hopefully, kind of lay out. One being that breast cancer is a complex disease. There are no two cases that are the same. And so what that means is to offer the best management from the very beginning, from prevention all the way through screening and diagnosis and management and survivorship, requires what Dr. Peterson mentioned, which was everyone engaged in that team, including the patient, is all on the same page. And that can only happen when there's discussions. We usually sometimes describe it as that breast cancer care is not a linear process where you bounce from one person to the next. It's more of a circular process where everyone agrees to the plan up front, so that the optimal plan is put in place. So I really wanted to emphasize that this is a personalized approach to every case. I also wanted to emphasize too that in this middle of this continuing COVID pandemic, we are up and running. We're very much aware of some of the limitations and fears and anxiety patients have, but we're here to screen, we're here to treat, we're here to counsel, and we are at full operation. So the last thing we want to say is be afraid to come in, because don't be afraid to come in. All of our facilities are open. We have all appropriate safety precautions in place. And we want to make sure that we provide the best care. So I think we're pretty much at the end. So I'd just like to thank everybody on the panel for spending this hour with us, leaving your schedules to come here and talk to our viewers. I want to thank everyone at home that's watching. We hope we were able to take away some good information that can help you focus on cancer prevention, the various treatment options. As you've heard through the program, Hawaii Pacific Health does offer a comprehensive service in breast cancer care, both for you and any of your family members. That can be anything from a virtual video conference, on the phone, in person. We're here to benefit you. If you do have any questions regarding either the program tonight or anything else, please visit the hawaiipacifichealth.org website. You should be getting a notice about a recording of this. And so thank you once again for joining us today, and please stay safe. And we hope we see you at one of our centers. All right, good night.